All righty. Well, we're back here and welcome everyone. We're so happy to be kind of starting up again our season, our new academic year, and with the first clinical conversation session of the year. And so I'm gonna introduce our speaker. My name, well, first of all, let me introduce myself. I'm Barry Serpett, and I'm the statewide medical director for McPAP. And I will be introducing our speaker and also kind of doing a little bit of housekeeping stuff, before we, get started. So, as you know, our McPAP clinical conversations are every month from September through June on the fourth Tuesday. And so next month will be on October 22nd. So mark your calendars. And just to also to say about the program, we are really pleased in this program to offer talks, on all kinds of different topics. We have alternated between doing sort of talks about some of the basics, of different kind of common psychiatric conditions that present, to pediatric primary care providers. And we also talk about some sort of special topics, and we go deeper on certain things and talk about some advances and interesting sort of new things. This year for our curriculum, we're going to be going back a little bit more to the basics. And so we're actually going to be revisiting, some of the sort of talks that we've given on our clinical algorithms, which have been also updated. And so today's talk is on obsessive compulsive disorder. Next month on October 22nd, we're going to have an update discussion about depression. And Dr. Bruce Waslick is going to be giving that talk. But for today, we are talking about obsessive compulsive disorder, and we are so pleased to have Dr. Yajie Yu as our presenter. And so before I tell you about him, just in terms of housekeeping, we are pleased to be offering CME for these sessions, and you'll see on the screen, if you're kind of at your computer or device, instructions for getting the credit. And you got to enter in the code. You have to register, enter in the code, for each time you attend a program. It's offered through Mass General Hospital's Continuing Ed department. And the code today is MUMJET, MUMJET. We record these sessions, and so they're available on the McPAP website at www.mcpap.com. We upload our slides to the McPAP website, which you can find under toolkits and resources. For today's session, we welcome questions because we are called the Clinical Conversations program. So we want to have a conversation with everybody and really talk about some of this stuff. So feel free to enter questions into the chat. And if you want to be unmuted, you can always just pitch your question yourself, or if you just write the question in the chat, we can read it for you. Either during the presentation, if it's relevant to what's being discussed at the moment, or we can save it at for the end. Lastly, just for housekeeping, please, we actually really appreciate feedback from all of you, and so we like to get survey responses. They're really quick surveys, and it's really important to us for improving the program over time. So let me tell you about Dr. Yajie Yu. Dr. Yu is at Harvard and is working at McLean Hospital, and he's one of our McPAP child psychiatry consultants. And so you may speak with him on the phone, and I hope you do. Dr. Yu received his medical degree from the University of Missouri Columbia branch, and he completed his adult psychiatry training at the Harvard South Shore residency program, and his child and adolescent psychiatry fellowship at Boston Children's. As I said, he is part of the clinical staff at McLean Hospital and is working within the McPAP program as a consultant. He's an instructor in psychiatry at Harvard Medical School. And he has special interests in ADHD and also in PIMU, which is the acronym that corresponds to problematic interactive media usage among youth. So without any further ado, I will hand off to Dr. Yu. And thanks again for giving our talk today.
Thank you so much, Barry. All right, let me go ahead and share my screen. Share window. And... Okay, can everyone see this? Okay, looks
yes,
good.
looks fine.
Oh, perfect, awesome. Hi everyone. Welcome to the first MCPAP clinical conversation of the year. Again, my name is Yajie. I'm a consultant at McLean. I don't know if Barry mentioned this or not, but maybe we'll, just because I can't see everyone's screens, maybe we'll have the questions at the end, but if someone really has a burning question, please feel free to unmute yourself, shout it out, and I'll do my best to address it during the slide. All right. I do not have any conflict of interest disclosures. And for today, we're going to talk about OCD. Essentially, what is OCD? How frequent do we see it? How do we assess it? How do we treat it? And then there's this sort of like another similar psychiatric condition called PANDAS. We'll talk about what it is when we consider it versus OCD. Right. And we can start by, defining OCD, and that is a condition characterized by obsessions, compulsions, or both. And we'll talk about each of the components as well. And typically, this is a set of symptoms that cause a lot of distress and could interfere with daily functioning for, the patients, the families. And however, there are times where mild OCD can be difficult to detect. So for example, they might not be caught for months to years until there's a severe enough exacerbation that, schools or friends or peers, will notice it. Okay. All right, so we'll talk about obsessions first. So these are unwanted intrusive thoughts and images, with the emphasis on kind of like the unwanted and intrusive parts. So some examples are, someone might have fear of germs or dirt, and we'll say like, oh, this is contaminated. They could have fears of making a mistake, a need for order, neatness, symmetry or perfection. And then, or they could have concerns of harm to themselves or to others. And sometimes it could be, sexual harm, intrusive thoughts of sexual harm to others. And compulsions are repetitive behaviors that are performed in response. So some examples are, they could arrange things in a very specific way. They could be washing their hands over and over again. Like this is, not like if you touch something, like touch dirt and you wash your hands once or twice. This is like 7, 8, up to 10 times. Repeatedly checking things, checking the lights, checking the oven, checking to make sure your door is locked. Or have specific, like assign importances to numbers. So for example, doing things by sets of 3, doing things by sets of 4. Like having to, take 3 steps to the left and then switch to the other side of the hallway, etc. Okay. So what is the relationship between obsessions and compulsions? Well, so for instance, if we take the example of fear of dirt or germs, like a contamination fear, this often leads to anxiety. For example, a young patient might, feel like they've touched something that's unclean, and that causes them a lot of distress. And so in response, they will perform the compulsion of washing their hands repeatedly, 3, 4, 5, 7, 10 times. And what that does is it temporarily reduces the anxiety and helps them feel better. So it's kind of a reinforcing cycle. Unfortunately, the relief is often short-lived, and they feel better for a couple of minutes or 20, 30 minutes, but then the obsessive thoughts come back and it starts the cycle all over again. So how often do we see OCD? Well, in the general population, we think the prevalence is about 2%. So that is approximately 1 in 50 individuals. So most of our colleagues in the audience who have a pediatric practices will probably see a handful of cases every year, at least. And the age of onset is typically around adolescence. So if we look at this chart of where OCD typically occurs, you see that by like the three big bars in the middle, from 11 to 25, those are when you see the bulk of the cases. And I would say that just, eyeballing this chart, about 75% of cases do present prior to age 25. So it's pretty rare for individuals to have it before age 5 and pretty rare for individuals to have it like after age 40. And then we'll talk a little bit about the neurobiology of OCD. And this is probably the most complex slide in the entire presentation, but we'll take it, one step at a time, and we'll come back to this a lot. One of our best understanding in 2024 about how OCD happens is it's a it's a disruption of the corticostriatal thalamocortical circuit. So that's the CSTC. And I, in med school, was not very strong on neuroanatomy, so we'll talk about this and the individual parts. And what I found helpful is sort of as a learner, is the color code thing. So we have the three parts that are based on colors, and I apologize if anyone is colorblind. I should have thought of that. So we'll talk about the frontal cortex first. And normally, the frontal cortex is helpful for, complex decision making, evaluation of emotional stimuli. Like something happens in our brain. This is sort of the deeper next level, like analysis. How important is that thing that has happened? In OCD, there tends to be an exaggerated sense of importance to danger or emotional events. So something like, for example, if someone touches, a handful of dirt, normally you would say, oh, there's a bit of dirt, I'll wash my hands once, that'll be fine. Whereas for someone with OCD, they might say, oh my goodness, this is contaminated. I have to wash my hands over and over again until they're clean, or something bad could really happen to me, or this could get me sick, or could really, make my family sick. The next part we have in green is the striatum. Normally, this is helpful for habit formation, procedural memory. However, in OCD, the striatum tends to be hyperactive, and that leads to the repetition of behaviors that we see over and over again. And then finally, oops, I'm going to move this window real quick. Here we go. For the thalamus, normally it acts as a relay station between the different parts of the brain. But in OCD, there is increased attention to intrusive thoughts and actions. So it's sort of like instead of prioritizing tasks or procedures that are more important, it says, hey, focus on these intrusive thoughts and actions. And unfortunately, all of those together contribute to the symptoms that we see of OCD. And we'll hold this idea very briefly, and then we'll come back and talk about how to treat it later on. Okay, so what are some of the common comorbidities of OCD? Well, you have anxiety and depression, which are the most common. You have ADHD, which occurs around a third to half the time as a comorbidity. Tic disorders, when I saw this, I was actually pretty surprised at how much more prevalent it is than I thought. It's about a fourth of the time. And the important aspect is that when you see hyperactivity or tics, you want to consider possible PANDAS, and we'll talk about PANDAS a little bit more at the end. When you evaluate these common comorbidities, of course, consider further assessment if you think that there's hyperactivity with Conners or Vanderbilt's. And also, sometimes when kids come in presenting with OCD symptoms, they'll also have possibly restricted interest. And when you talk with their family, they'll say that this has been happening, way before the onset of OCD symptoms, and so you want to consider pursuing workup for autism spectrum disorder as well. Okay, so now we get into how do we assess for OCD. One of our best tools that we have is the PsyBox. How many of you here have heard of the PsyBox? Maybe raise your hand. Okay, so maybe a couple of individuals. So PsyBox stands for the Children's Yale Brown Obsessive Compulsive Scale. And it's helpful because it's a very nice two-part scale. And the use of questionnaires could be helpful in helping provide the children, with language to describe their compulsions and obsessions. And oftentimes, when I talk with younger kids who are like, maybe 7 or 8, they'll say like, "Oh, my brain makes me think of bad things," or "My brain makes me do bad things." Like, and then they don't necessarily have the language, but when you ask them, "Oh, with a questionnaire, do you have some of these?" They'll be able to use some of the language and be more specific in describing their symptoms, which can be very helpful in treatment. Okay. Um, so the first part of it is the symptoms checklist. So remember the little image boxes that we talked about earlier of what OCD can present like. Well, essentially the symptoms checklist is the written form of, and it goes into a lot more details and specific nuances of what potential obsessions and compulsions are happening. And this is basically like if it's happening now or if it's ever happened in the past or both. And the second part of it is a severity scale where it goes from 0 to 4 and it breaks it down into obsessions and compulsions. So it's like, how much time do you spend on the obsessions or compulsions every day? How much do you feel like it interferes with your, regular activities? How much does it cause you distress? How much do you think you're able to resist the pull of the obsessions or compulsions? And then finally, how much control you think you have over these compulsions and obsessions. And so at the end, you tally up all the scores and it goes from anywhere from 0 to 40. And I'll have you guys keep that number in mind because it goes from 0 to 40 and we'll talk about treatment based on the scoring at the end. Okay. And so during the interview, you want to remember that OCD can be very disruptive for patients and families. It's helpful to get a sense of how it affects the patient on an individual basis, but also it's great to interview the family members and see what the impact is on the overall family unit. One important aspect is when you're taking the family history, ask about anxiety disorders and autoimmune disorders. The emphasis on autoimmune disorders is that it could be there could be a higher incidence of, let's say, PANDAS or PANS if a parent has any sort of like a thyroid or autoimmune disorder. And also, you want to ask about family members, and they could possibly identify accommodations. And what an accommodation is that sometimes families will often inadvertently do things that could reinforce the compulsion. So for example, if a child is afraid of germs, contamination from going outside, a parent might say, well, that's fine. We'll help you out by, we won't go outside. And from their perspective, it's well-intentioned, but unfortunately, it does reinforce that cycle of OCD. And so we'll now talk about treatment. And I want to mention the POTS landmark study. And this is the pediatric OCD treatment study. It's one of our famous studies in child psychiatry. And essentially what they did was they took the SIBOC score, from the severity rating scale. And then over the course of 12 weeks, they split the individuals into 4 groups. So for the placebo group, over the course of 12 weeks, they got the placebo, didn't really help too much. They tried sertraline and SSRI, and they found, over 12 weeks, this actually worked pretty well. Then they tried CBT. For the CBT group, they said, wow, this worked really well. So much better than medication. But then when they combined CBT plus sertraline, that showed the absolute best results out of all the groups. So essentially, to summarize, CBT, this is kind of a recurring theme in treating psychiatric disorders. Medication plus a therapy tends to work the best. And so, based on the evidence from these studies, this forms the basis for our MCPAP guidelines. And don't worry, this seems like a huge wall of text, but I'll go over everything in specific details. Okay. So going back to the SIBOX, if you remember, if you get a score of 0 to 15, so that's like subclinical to mild, your first line treatment is, again, based on our evidence, CBT/ERP as the first line. So what is ERP? ERP stands for exposure and response prevention, and it's a specific type of like a CBT therapy. And so the example is if you think back on the cycle of obsessions and compulsions, where it loops over and over again, the idea of ERP is exposure and response prevention. We stop it before, so we expose the patient to the thoughts, images, or situation, and then we stop it. And basically, that means to gently guide the patient to resist the urge of performing the compulsion. And so over time, this weakens the need to do the compulsion, and it also reduces the symptoms gradually as well. So pretty neat. So what do we do if the psi box is, 16 or above? So 16, like moderate, and then up to 40, which is extreme. So in addition to CBT slash ERP, we add an SSRI. And which medications do we use? We use one of these three SSRIs. So sertraline, fluvoxamine, fluoxetine. These are the FDA-approved medications for treating OCD. And the doses are, there's a starting dose, a target dose, and a maximum dose. And don't worry, we have this in our guidelines, so you don't need to jot down the specific numbers. I'll talk a little bit more about the concept of this in a little bit. So why do SSRIs work? So remember, one of our theories is that OCD occurs partly due to dysregulation in the serotonin pathways. So in theory, could there be low serotonin? And if we increase the bioavailability of serotonin via SSRIs, the symptoms tend to get a lot better. And that helps to basically forms the basis for our treatments. Okay. And so how do you monitor the treatment? So once you start an SSRI, you gradually go up. And you want to monitor their symptoms every 4 weeks until maintenance is achieved. And you use the psi box, and ideally we'll see the severity gradually go down as we increase the dose of SSRIs. You titrate the medication towards the max dose, and that's sort of like as tolerated and as indicated. And you continue the CBT and ERP in the meantime, because you don't want to, once you have them on a medication, you want to continue synergizing it with the therapies as well. And only after 1 year in remission, you can gradually, consider gradually cutting back on the dose of the medication. Something interesting to note is that compared to, just depression and anxiety alone, you might need a slightly higher dose of SSRIs in order for the patient to respond. So that's just something to consider as well. So, whereas with if someone just has like GAD or depression alone, they might do well on a medium to moderate dose of SSRI. Whereas with OCD, generally the literature says that they tend to require a higher dose of SSRIs, which is why in the table a couple of slides back, there's the target dose, and that might be higher than what you're used to seeing or what you're used to using in your clinics. Okay. So that's mostly the treatment of OCD. And then we'll talk about PANS and PANDAS and when we consider it. So what exactly are, PANDAS and PANS? So PANDAS is the pediatric autoimmune psychiatric disorder associated with Streptococcus. So it's due to for a specific bacterial infection. And then PANS is the more general pediatric acute onset neuropsychiatric syndrome. So it's sort of a overall immune response. It could be to bacteria, it could be to viruses. And the basis behind it is you have autoimmune antibodies that mistakenly attack the basal ganglia after an infection. And that causes OCD-like symptoms. So when do you consider it? Well, if you have a sudden onset, so typically OCD can be more gradual. It can take, months, sometimes years for the symptoms to gradually ramp up. Whereas for PANDAS and PANS, the more typical clinical story is that you have a younger child, let's say they're under 6, and parents will notice that rapid onset within weeks, within a month, kid gets strep, they get better from strep, but then all of a sudden they start having these severe OCD-like symptoms that seem to have come out of nowhere. And so part of your assessment is that you want to test for and treat active infections that could be there. Other basic labs that are helpful are immunoglobulins, CBC for basic blood work, ANA just to see if there's any general inflammatory processes going on, ferritin, B12, vitamin D. These three are non-specific, but oftentimes abnormalities in the labs could help narrow down certain etiologies. You also want to check viral or bacterial testing. Especially, if parents report a clinical history that the kid had strep throat a summer ago, check for anti-streptolysin O, which is an indicator of previous infections. And then there is also what's called the Cunningham panel, which I think a lot of our colleagues in pediatrics have heard about it. And this is basically a set of biomarkers that when you have pandas, these markers are elevated. There's not like a causal relationship with any of these in particular, but the group, if multiple of these markers are elevated, that can often be associated with individuals who are experiencing pandas. And something to keep in mind is, this is very complex. Even with pandas, PANS, OCD, anytime there's questions about what to do next, please feel free to always call us, and we would be happy to help walk you through or guide you through the process. So I believe that is the overall presentation. I want to open up to questions, but also give a shout out to Dr. Charlie Moore for helping to provide some of his previous slides, which I was able to use to incorporate.
Thank you so much, Dr. Yu.
Of course.
So yeah, so I don't have any questions in the chat yet, and so we may have time to talk about any more, if you want to go any deeper on any of your slides, but I think we'll see what we get. And but before we do, I just want to tell people that, just acknowledge that there was a problem with the CME code that I told you about and the instructions we gave in the beginning, but it has been resolved. So it seems to be fixed, and people send the code, which is in the chat, to the number that's indicated. It will be received, and we're going to also send an email out to everybody who's registered for the talk, just to let them know about the instructions. So we have two questions. The first one is from a person by the name of Jan S, and they're saying, what do you do next after SSRIs if they're not effective?
That's a great question. So typically, our best evidence is that you have SSRIs, and you want to try multiple SSRIs first. This is really a case where our best evidence by huge margins is that SSRIs are the most effective in treating OCD. So you want to try, sertraline, fluvoxamine, or even escitalopram. I know it's not specifically FDA approved, but in theory, it is an SSRI that works, that's well tolerated. It works wonderfully. And so that is, something else to try as well. In cases where individuals fail multiple SSRIs, there are second-line treatments. So, the reason I didn't include it was because it's not quite part of our MCPAP guidelines yet, because it's way more complex, and hopefully we don't get to that point. But clomipramine, it's oftentimes there's good evidence for the use of clomipramine. The tricky part is that there's a toxicity level, and you have to do blood testing, and oftentimes it could work moderately helpful, but it's so complex. There's more side effects that typically it's very rarely done on an outpatient basis, at least in the primary care setting. So if a patient fails, 2-3 SSRIs, certainly give us a call, and we would be happy to, consider clomipramine. And in the Massachusetts area, we have the wonderful OCDI Junior at McLean Belmont, and they're kind of a world-class facility where the toughest, most treatment-resistant OCD cases of kids and adolescents come from all over the world. And they do, in addition to clomipramine, I think they also consider, there's more research and development of new modalities that could possibly work. Yeah,
Awesome.
but unfortunately,
Yeah.
aside from SSRI, clomipramine, there really aren't too many great tools that we have at this time.
Yeah.
But the good news is SSRIs are phenomenal in that the vast majority of individuals respond.
Yeah, a couple. I'll sort of chime in a little bit if you don't mind, and just
Please.
say that these kinds of times where you sort of need to escalate the treatment plan. That this is, or if your trials of first line medications aren't effective and the patient's still having trouble, this is a perfect time to call McPAP, just to discuss, because some of the things that we haven't talked about as much intentionally is off-label treatments, and there's kind of like a decision tree, and when you get farther and farther out on the limb, you sort of get into things that aren't sort of considered evidence-based treatments that might need to be considered, and that's kind of where specialist referrals, increase in the level of care, can be considered depending upon the patient's, degree of function. And then, sort of consideration of things that are more complicated, like, clomipramine. I'm sort of stumbling over the words. Anafranil. That's
Yes, anafranil.
Yeah, but we actually, I'm not supposed to say that because our CME accreditation sort of requires us to use generics. So I will learn how to say clomipramine, without the tongue twister. So yeah, there's other questions. So this is really, the chat is kind of lighting up. So could you speak about referrals for CBT and exposure and response prevention type, sort of specialized CBT for younger patients? Do you have any thoughts as far as how to access that?
Yeah, and I'll talk about it when you say younger patients, and I'll say, there's kind of a typically for anyone like 6 and above, it's much easier to get therapy referrals. This is for, CBT, ERP, or supportive psychotherapy in general. More practitioners tend to specialize in older kids. When you get to individuals of 5 and under, that tends to be much more difficult just because of the number of providers available that are comfortable in working with that age group. With that being said, your question on what's the referral process specifically for McPAP, we have several wonderful social workers. I think Mark Tucker is actually here. I want to give a shout out to him, who's been phenomenal. Typically what you do is you call our McPAP lines and you talk to the coordinator and you say, I have an individual who I suspect has OCD. Can you send me to the resource specialist to talk about, to send some resources, therapy, CBT, ERP referrals? And based on the patient's location, insurance, our social workers tend to do a pretty awesome job of sending the resources either to the family or to your clinic directly. And of course, if you want to talk about, starting a medication in the meantime and want to speak with one of us CAPs, we would be more than happy to talk about the case with you, provide initial medication guidance, and we can also at the same time, send a note to our social worker colleagues to help with the referral process.
Great. Thank you. So I'm going to read this one because it's better to have the question. It's a little bit of a nuanced question. It's from Aaron B. It says, my experience in the community, which is southeastern Massachusetts, is that the type of therapy offered, whether it's CBT or other, does not seem to help my patients with OCD. And we have only had better success with places that specialize more in OCD. Do you have recommendations for groups, not in the immediate Boston area necessarily, which have particular expertise in OCD?
Yeah. Oh my, that's hi, Dr. Bornstein. That is a tough, specific question. I don't know if Barry will be able to help. I guess for me personally, I don't know of any specific groups that are of therapists that are like the best at OCD or the best at ERP.
Yeah, that's okay. I wasn't quite sure if the person was wondering about group therapy modalities or groups of specialists. But
I interpret it as like do you know of a special like group
Yeah.
who have particular success
Yeah.
or would be, yeah, and unfortunately I don't.
I think so. And so it's sort of more of a group of professionals as opposed to a therapy group. There, at the end, I do want to call out sort of that person, Mark WT, called out a program called In Stride. And that's kind of a virtual only program that actually has ERP built into it. There's kind of a combination of coaching and sort of online work that the kids do, but they provide a lot of support, and they also, I believe, provide some care coordination for kids in terms of trying to look at, sort of getting a comprehensive kind of treatment plan put together for them. But they accept kids from 7 to 22. I believe that they used to be affiliated with McLean, if they're not still.
I think they were a couple of faculty members that came from McLean and different Harvard hospitals, and they formed the InStride group together.
Yeah,
I think
so
that's the association.
Yeah, thank you. And so we see some nice sort of chiming in on InStride. Someone named Melissa said that she finds InStride to be, really, really helpful. And someone named Aaron B said our best success has been, or that's the person who asked the question, with InStride as well. But they don't, unfortunately, take all insurances. I think they're trying to get on network with as many as they can. And he also said that I've had patients utilize the National OCD Foundation out of Chicago and have had some success virtually with them, but it's hard to find in-person services. Yeah, someone else said that InStride tends to get kids in quickly, which is, of course, always. So another question, will relapses, this is from an unknown user, will relapses be lifelong, or do OCD symptoms resolve and sort of go into remission?
Yeah, that's a great question. So I think off the top of my head, the literature so far says that, of course, this is different for everyone. In general, a subset of the population, especially with milder and moderate OCD, over time, as they get older, the symptoms actually get a little bit better. So there could be a significant portion of the population of young adults out there who may have had more severe obsessions or compulsions in their childhood, never got diagnosed, never got treated, but then over time they gradually get better. However, on the other hand, as with any sort of psychiatric conditions, psychosocial stressors, big changes in life, trauma could certainly exacerbate or cause worsening. So I guess it depends on an individual person-to-person basis. I hope that sort of gets at the question.
Yeah, I think it does, and we can always see if there are follow-up questions in the chat from the person who asked, but I would sort of add that, so it's true that, there's a certain kind of natural history of different syndromes, where, you sort of, we know autism changes, sort of over the course of life, and the symptoms, become different. In some ways, functional status can improve kind of just with development. And anxiety disorders writ large, including OCD, I do believe there's a fairly convincing literature that suggests that the symptoms tend to relapse, like when someone has a medication response. We like to think of remission as a goal, and the idea of remission is that you might discontinue the medication and the disease does not recur. And then another way of thinking of remission is that the treatment is really completely sort of reducing symptoms to the extent that they don't any longer qualify for the diagnosis. And so that certainly can happen, that OCD, can go into remission, but it's unlikely, that people will sort of be able to sustain their remission if they've had a medication response and the medication is discontinued. It's not impossible, but it's very likely that it will recur. which is a little bit different from depression. I mean, we all know that some patients and many patients have recurrent illness with depression. Anxiety disorders tend to rear back up, I think, more commonly when the medication is discontinued. So do you agree with that, Yajie, as well?
Yeah, absolutely. And I think the way that I interpreted the question was for individuals who like never started a medication, but certainly, and I think I may have saw this like a similar question pop up, and I'll address it at the same time. If someone is doing well on a medication, should they could they stay on the medication, indefinitely? And I think the evidence does support it. As long as you're tolerating the SSRIs, you're not having any significant side effects, or if the side effects are so mild that when you weigh it against the potential harms of these ongoing obsessions and compulsions, I think the literature is supportive of individuals staying on SSRIs for extended years, decades, as long as it continues to help them with their symptoms. And for individuals who, do stop the medication, yes, I think oftentimes the OCD symptoms can come back.
Mm, excellent. And actually, you answered one of the other questions already in your answer to that question, because from Jan S, she wrote, or they wrote, I have several patients who have responded to SSRI and do not want to taper off their medication. Do they have to come off the medication? And I guess, from your answer, the answer is no, right? Yeah. Okay. I actually want to talk a little bit about, what your target, is when you're treating patients, with OCD. That we have sort of information or algorithm as far as, the targets that you would watch, for medication titration and things like that. And I guess I just want to put out there that in my clinical experience, it's very uncommon for patients with OCD to really sort of have their syndrome completely go away. That we're sort of looking for, based on just being realistic. I think that we're sort of pointing or sort of striving towards kind of really restoring functional sort of status, sort of the functional, kind of restoring function. Right. And we also want to relieve, symptom burden and reduce suffering. And so that's another, endpoint too, that we don't want to leave people, feeling, in pain, from their symptoms and be tormented by them, just because they're functioning, so really both. But we're not seeing sort of people being able to, completely let go of all their OCD symptoms and their urges and tendencies. And that's just a fact of life, that we certainly would love to be able to do that. But the reason why I bring that up is because that's something that, just framing expectations is really important, that you don't want to take away hope. But you also don't want people to be sort of thinking that they need more and more medication in order to chase after sort of what's a less realistic goal, which is complete, symptom remission. So what do you think about that, Dr. Yu?
Yeah, so I think as a prescriber, I'm not an absolutist. I don't think of OC as like a present versus absent type of thing. And oftentimes I like asking the patient and the family, like, hey, what do you hope for the best case scenario to be, in terms of like functioning, in terms of how you're feeling, in terms of how you guys do as a, family unit. And I work with them, and during treatment progress, oftentimes they'll say like, oh, I think patients and parents often have a really good sense of how the treatment and medication is working for them. They'll say like, oh, I see my child's symptoms way better. They're no longer spending 4 hours in the bathroom washing their hands or fixing their hair to make sure it's perfect. And then they say like, oh, I think based on this level of like at the current medication, we're happy with what we're seeing. Or they're like, I think there's still some challenges. And I talk with them and I ask, are there any side effects? Are you guys, and I basically make it like an informed decision / team discussion on if they want to increase the medication further versus leaving it the same. there are times where I say, where they're like already maxed out on a medication and, patient is, let's say, like 75 or 80% better. And they say, like, well, this isn't perfect. Could we try something else? And I talk with them and I say, we have an objectively fairly, responsive outcome so far. We could try another SSRI. However, there's no guarantee that it'll be better or even just as good as this one. And then I talk with them through of like the risks and benefits of staying the same, and oftentimes families are able to make a pretty good decision based off of that.
Great, great. That's in keeping with my practice too. Um, we I just add one point just from my own patient population that I'm sort of going through in my mind, sort of the patients who have been able to get off of meds. And so far I can't think of any of them who did not do really good psychotherapy work with, particularly with ERP. Um, and so at least there, it's hard to get this signal from the studies because the studies haven't sort of been subject to as much long-term follow-up. But I think there is a signal that indicates that psychotherapy can really increase your likelihood of being able to get off your SSRI, and that's been seen with depression too. So we have a few more interesting questions. Actually, I'm so glad that the chat is continuing to light up. So Jan asked, do you recommend referral to specialty for patients with PANDAS and PANS, or who is suspected, to have that, rather than trying to manage these patients in primary care setting?
I do, and Dr. In our work with in my work with McPAP and such as pediatrician colleagues such as yourself, there are cases where when I suspect PANDAS in a phone conversation with a pediatrician, I usually say MGH has a really great PANDAS clinic, and even as a psychiatrist, primarily on a outpatient consultation basis, I think there's a limit to my knowledge as well, based on what I can do to further diagnose and treat PANS. I think if I were in another state where there's less support, I might try to do some of the additional workup, such as Cunningham panel myself. However, we're in Massachusetts. We're blessed to have so many specialist colleagues who have these like specialized clinics that I think it's absolutely worth letting the world experts take a shot at it.
Yeah, that makes a lot of sense. And I guess I would also add that this is kind of like a patient preference issue too. As well as a pediatrician interest, and so, you have a lot of options as a pediatrician. You can try to refer the case to specialty care. You can get a McPAP consultation. You can get a consult, from the specialized PANDAS PANS, group that was mentioned. And so that it's not sort of like necessarily a binary decision as far as specialist or not, because you can get some help from a specialist without necessarily letting go of the patient. And sometimes the patients really don't want to have a disruption in their clinical relationship and sort of be sent, to other people if they have like a really solid relationship with their existing provider. So I would say, it's not sort of necessarily a one size fits all, but I do agree with Dr. Yu that it makes sense to, sort of, if it's possible, and if the patient is willing to involve, people who have, the most specialized knowledge about this, because it is complicated.
Yeah. And just, oh, go ahead. Sorry.
No, please. I was going to go into that.
I was going to say, just as an add-on to that, I think one practical example of a difference is that I've had McPAP, consultations where I've seen a patient from a pediatric practice, and based on the history examination at the end, I say, if I had to put money on it, I would say this is likely PANDAS. Here are the labs that I would recommend, like ANA, IgG, CMP, things like that. But that's sort of, unfortunately, on an outpatient basis, that's where the limit of my knowledge and expertise and ability to treat stops. So for instance, one potential treatment kind of like further down the line for PANDAS or PANS is IVIG. And in those cases, referral to larger academic hospital specialty settings can be helpful in getting the patient to the next step of the treatment, because I don't think IVIG is doable on an outpatient basis. Yeah, or if they need additional workup for autoimmune disorders, sometimes they do like MRI, CTs, other panels. That is typically much more suited in a larger hospital setting where they would also have colleagues from infectious disease, neurology who would also be able to weigh in. And oftentimes, PANDAS is so complicated that in addition to psychiatry, it's a multi-specialty collaboration treatment.
Thank you. Actually, to that point, there's another question at the end of the chat about who is the best specialist to evaluate for PANDAS. Is it psychiatry? Is it infectious disease? Is it rheumatology? So you mentioned a specialty group, and you could sort of reiterate that. But I assume that the specialty group sort of is located in psychiatry, and that they involve some of the other specialists kind of on an as needed basis and try to coordinate that. But what would you say about
I
that?
think that's correct. Unfortunately, I don't want to like take a guess and then be wrong. But typically, all of the having trained in Boston, the nice thing about I think culturally, academic institutions in Massachusetts have this kind of ways to incorporate different specialties. So, for example, even like long COVID, Boston Children's has a long COVID clinic. Boston Children's has a GEMS, like a specialty gender multidisciplinary. Boston Children's has an eating disorder clinic. And all of those aren't necessarily embedded in one department. It's more of a collaborative project between like psychiatry and adolescent psychiatry, neurology, psychiatry, and rheumatology. So I think it's really hard to split to say that like, oh, this specific clinic is under the blank department when it's more of a collaboration of colleagues from a lot of different like for example even within I think within the MGH pandas clinic they have psychiatrists, they have neurologists, they have internists who different individuals specialize in different pieces, and a family will work with not just one but everybody.
Yeah, so it's really a multidisciplinary
Yes.
kind of approach, and I guess it depends, which department is the home of their program, but it's going to be
Yeah.
right. And so, just to remind people again that if you have a suspicion of PANDAS, you shouldn't be holding that all by yourself. You should definitely feel free and be encouraged to be talking with McPAP, and call the hotline, and we can sort of try to navigate some of the options and for the different kinds of resources that exist, and use our resource and referral folks as well for helping to find providers who can deliver exposure response prevention style CBT and other kinds of resources like for PANDAS and stuff like that. There is a question, we're getting towards the end.
Barry, there's one question there about is there evidence for stimulants being an adjunct to SSRIs?
Yeah, I was going to read that, John. So stimulants plus SRIs for OCD. What are your thoughts, Dr. Yu?
Oh, I'm actually stumped on that one. If this were a McPAP live call, I would be able to pull up PubMed and tell you a little bit more. But I will be honest in that I don't, right at this moment, I don't know. Yeah. Barry, could you step in?
Yeah, I actually don't know that either. So I'm not sure, what we certainly have stimulants, being used to augment antidepressant treatments for certain populations of depressed adult patients. So maybe it's kind of something related to that literature. But for pediatric depression, we don't see too much. I think, but again, for depression, it's really for more debilitated patients who have these kind of so-called neurovegetative symptoms, and it can sort of have a helpful effect in terms of boosting energy and increasing motivation and things like that. But again, we don't have any data that we're aware of, in terms of doing that for children with OCD. And then we have Dr. Shalagram from the Boston Children's team commenting that she would worry about worsening tics in terms of adding stimulant, especially given that it's not sort of evidence-based, for OCD. You could be treating a comorbidity. Obviously, if someone has ADHD, we don't sort of recommend against treating that, with a stimulant, even though, we know that there could be, tics, as an emergent treatment emergent side effect, but again, not for the pure OCD. It says that the MGH OCD clinic lecture listed it on a slide as a possibility. But yeah, so we don't know about that, but it's worth looking into. We can even sort of look into it and get back to the group via email if we find anything about that. Yeah, so I don't see any other questions. We have 5 minutes more, but we could end early. John, do you have any thoughts as far as any additional things to bring up?
No, Barry, I think it was really, I think you did a great job covering the subject.
Thank you for having me here, everyone.
Yeah, well, thank you again for fantastic talk, Yajie, and look forward to so you're part of the program, and I hope people get to talk to people in your region, get to talk to you from time to time, when they have questions. And we look forward to seeing everybody, hopefully, next month, October 22nd, for our session on depression. And then you'll get some updated instructions for the CME credit via email if you didn't already get the chat message. And we'll see you next time.
Have a great afternoon, everyone.